My name is Kriana Barat, and I am a postdoctoral research fellow at NDAC, and it is my pleasure to be hosting today's webinar. I'd like to begin by acknowledging the Whadjuk people of the Noongar Nation, who are the traditional custodians of the land from which I am joining this meeting. I'd also like to acknowledge the traditional owners of country throughout Australia, noting that our speakers and audience are joining from many different locations, both within and outside of Australia. We pay our respects to the elders past and present and extend that respect to any First Nations people present today. Now, it is my great pleasure to introduce today's speakers, that is a plural. We have Associate Professor Rebecca McKetin, who currently leads a program of research into stimulant use, epidemiology and interventions at NDAC. Her current research involves the online delivery of psychological help for people who use stimulants, the trialling of new pharmacotherapy options for methamphetamine dependence, and the development of novel responses to methamphetamine use in Aboriginal and Torres Strait Islander communities. Associate Professor McKetin is also joined by Dr. Taylor Deegan, who is a postdoctoral fellow at the National Drug and Alcohol Research Centre. Dr. Deegan is also a registered clinical psychologist working in private practice, and she's involved in stimulant research at NDAC, working on projects including the TINA trial. Now, in this webinar, we'll be hearing from Rebecca and Taylor, providing an overview of their work, reviewing evidence on the literature for substance use interventions. I am pleased that during question and answer time, we will have the opportunity to hear from Marika Ferry, Head of Sector Support to Practice in the Public Health Unit from the European Monitoring Centre for Drugs and Drug Addiction. Marika was one of the founding members of the Cochrane Drugs and Alcohol Group, and she has woken up very early to join us this morning, so we extend our great regards. Rebecca, Taylor and Marika will take questions from the audience after the presentation. You can log questions for the panelists using the Q&A function in Zoom. Please use the Q&A function rather than the chat function, and I will relay as many questions as possible to the speakers at the end of the presentation. But now I would like to hand over to Taylor, if you'd like to turn your camera on.
Hi, Kriana, thank you. As you said, Rebecca and myself are going to share the presentation today, and we're going to be talking about an overview of the evidence for substance use interventions. This was part of a technical report that was written, which I will provide a link to later on in today's webinar. I'd also like to just firstly acknowledge that this research was conducted as part of a project funded by the European Monitoring Centre on Drugs and Drug Addiction, the EMCDDA, and we'd like to just thank the staff at the EMCDDA for their expert opinions on the data collection and analysis methods. And as Kriana said, we are very grateful to have Marika here as well with us today, and look forward to talking with her a little bit more about the things that we are presenting today after. Next slide. So we know that understanding what interventions work is critical to provide evidence-based treatment and services to people who use drugs. It's particularly important for policymakers, for researchers, clinicians and practitioners to really know what works. And we know that gathering this information, it often requires really extensive reviewing and synthesizing of the literature, which can be very difficult and time consuming. We know that for policymakers, practitioners, time is of the essence. And so having to kind of filter through the information and evidence that is out there is really difficult. And it often requires a lot of kind of critical thinking and ability to really compare the reliability of sources to know what truly works. It's really important to then develop approaches to communicate both the evidence that is available and also how it should be understood. One way of doing this is to conduct an overview of reviews, also known as an umbrella review. It's a relatively quick and easy method, and Rebecca is going to later on today provide a bit of an example of what that might look like, to hopefully increase some confidence in being able to kind of go forth and conduct an umbrella review yourself. Therefore, we've done this. So we've put together an umbrella review which identifies the available evidence for substance use disorders interventions and rates. We talk a little bit more about the quality of this evidence today. So the first step in doing this umbrella review is that we searched PubMed. So we used a range of mesh terms, which again, Rebecca is going to talk a little bit more about what that looks like for us. But the mesh terms were related to cannabis, stimulant, and opioid use disorders. We searched the PubMed literature from 2010 to 2021 using mesh terms and focused on systematic reviews and meta-analyses only. Once this was done, we then selected the relevant reviews. And these were, again, systematic reviews and meta-analyses of randomized controlled trials only, as we know that that's the gold standard. We then extracted data and we took what's called evidence statements from all of the latest comprehensive reviews. Once we took these evidence statements together, we then used the Cochrane grade rating system to then rate the quality of the evidence. As you can see here, this is the key that we use or that we use for the evidence ratings. On the left-hand side, under key to the ratings, this is based on the Cochrane grade rating system. As you can see here, the number of stars, it indicates the quality of the available evidence, which reflects our certainty or confidence in the evidence itself. And then the color of the stars indicates the direction of the intervention's effect. So I guess just as an example, you can see there high quality, moderate quality evidence is represented by 3 to 2 stars. And this kind of just indicates that the intervention that we're looking at, it should produce changes in the indicated direction. So we can be fairly confident that what the intervention is, that what the evidence is suggesting is accurate. You can then see under the low quality, that's represented by 1 star. This is suggesting that the intervention may not produce the expected effect and that we really need to be really cautious in terms of interpreting those results and kind of in terms of how valid that research might be. Then you can see that the last one there, the question marks, that is representing that the evidence is of kind of lower quality or very low quality, or it's quite insufficient. So this again, highlighting more studies are needed and more studies are needed before we can really be certain and to draw clear conclusions about whether this particular intervention is effective or not. I'm now going to hand over to Rebecca, who's going to talk a little bit more about an example search and how an overview of reviews is actually conducted.
I think I have no camera.
Yeah, you're good to go. I can see you.
Oh, excellent. I'm so sorry, everyone. So yeah, I'm going to run through now what an example search would look like that we did. And I'm keen to do this because it's something that you can all do. What I'm going to show you is actually probably a bit of a Philistines version of an umbrella review. But in some ways, that's what makes it so accessible and appealing. So we use PubMed. It's freely available. Anyone out there can use it, even if you're not attached to a university or a library. You need to use the advanced search options in PubMed, and I'll show you how we did that in this particular study. Just have to bear with me because my forwarding of the screen is a little bit clumsy. So as Taylor mentioned, the first thing you do is you need to identify the mesh headings, or at least this is how we did it. You can always just throw a search term in and see what you get, but yeah, it's a little bit dodgy. So the mesh headings are a little bit more clear in terms of picking up the relevant literature. And how you use the mesh headings is you do a Google search for medical subject headings and you find this page. And when you go in here, you can click on all terms, or here I'm just going to put main heading because I want to find out what mesh headings map onto methamphetamine. You can see here when I've done this, thankfully, there is actually a mesh heading called methamphetamine, and that makes my life much easier. You can also see all of the things that that's capturing. So you don't need to additionally search for methamphetamine, which is an alternative spelling, or some of these other drugs, which frankly I wouldn't have been interested in anyway, but you can get an idea of what comes under methamphetamine. You can also look at the tree structure here. And this tree structure shows you the branches on the mesh headings. And this is great for getting rid of things that you don't want. You can see up here, there's a term called amphetamines. Now, you might naively put that into your search term, and what you would inadvertently do is capture a whole lot of things down here, including ecstasy and amphetamine, which in this case, I wasn't interested in. So I can see here that methamphetamine is the good heading I want, and up here I also want amphetamine. So going back to our search, you can just add these to your box, and then you can save this. You can either download it or cut and paste it, and then you hit go. And you get way too many papers, of course. You can't search through them all, but there's a convenient feature on PubMed that came about relatively recently, which is why we chose this method. You can select meta-analyses and systematic reviews, and bang, it really cuts it down a lot. And then you can control the time span. So in this case, we only went from 2010 up until the date of the search. But if you want to just look for recent reviews, you can constrain that even more to reduce the number of papers. Now, in this particular review, we were only interested in evidence from randomized controlled trials. So once we had done our search, I'll just go back. You can't see it here, but there's actually a button in PubMed that you can press, and it will export all of these results into a nice Excel spreadsheet, and it makes it much easier to go through. And this is actually the output. And so our team, what we did was we went through and we got rid of anything that wasn't a randomized controlled trial or anything that wasn't relevant. So it might be a RCT of dexamphetamine for ADHD, and that's not what we were interested in. So we got rid of those. And then eventually what we did was we focused in on the more recent and the more comprehensive reviews. But before doing that, we downloaded all of the abstracts, and then we went through and we extracted a bit of data on the population, the interventions, and then a summary of the findings. So then from the most relevant papers, we took out what we called evidence statements. And you can see here a really good example of one. And all Cochrane reviews have these, which made our life so much easier, where not only do they tell you what they found in a very succinct way, but they also tell you what the Cochrane quality rating for that evidence was. So you can see this one, they've actually stated very clearly that there was very low quality evidence that psychostimulants improve sustained cocaine abstinence. So when I tell you this, don't throw spears at me. This is just what the review found, and I'm just the messenger reporting on these findings. You can see here similarly moderate quality evidence, which is higher, as Taylor went through, that psychostimulants did not improve retention in treatment. So we extracted all of these evidence statements, and I want to just give you a bit of a flavour for what they look like. I'm going to go through some of the findings, but not all of the findings, or we'll be here until midnight. So for cannabis use disorders, the overall finding was that the evidence was low quality. So remember what Taylor said, that means it might not do what we think it does here. What we think it does is that psychosocial interventions, including digital interventions, may reduce cannabis use and cannabis-related problems, so that's positive. But there's similarly low quality evidence that the different pharmacotherapies that have been trialled may not improve treatment outcomes for cannabis use. Onto stimulant use disorders. What we can say from this is psychosocial interventions help reduce stimulant use compared to no treatment. So doing a psychosocial intervention is better than doing nothing. And there's moderate quality evidence for that. So we can say that with pretty good certainty. Amongst the psychosocial interventions that are available, when you compare them to just whatever you'd normally do in treatment, contingency management stands out. And there's moderate quality evidence that contingency management can reduce stimulant use. And it is specifically increasing periods of abstinence from stimulant use compared to treatment as usual. Of all of the other treatments, there's not such strong evidence that one outperforms the other. The pharmacotherapies, as you probably know, we don't have great evidence on that, but interestingly, there's actually moderate quality evidence, which is pretty good, that psychostimulant pharmacotherapies do not improve retention in treatment. And I think that's important because we often hope that they will. So at the moment, the situation is we have shown that they don't. In terms of whether they can reduce cocaine or amphetamine use, this is quite interesting because you can see there low quality evidence on both sides, and it's green, like stimulants may be associated with a reduction in cocaine use, whereas for amphetamines, no, they may not be. So that sounds a bit weird. But what's really going on there is in both cases, it's such a small change in outcome. For the cocaine use, it was statistically significant. For the prescription stimulants on amphetamine, methamphetamine use, it wasn't. So what we can say about that is at the moment, the jury is still out. We still don't know definitively whether or not prescription stimulants can reduce stimulant use. And what does seem to be the case is it's a very small effect. We've got really good evidence in comparison for opioid use disorders. We know that methadone reduces heroin use more than other non-agonist treatments. We know that buprenorphine at appropriately high doses is as effective as methadone. And we also know that CM, or contingency management, if you add that onto opioid agonist treatment, you can actually reduce the use of other substances like cocaine and other stimulants, which often co-occur with opioid use. So there's a potential treatment option. And unfortunately, and this seems a bit contrary, there's really good evidence that adding psychosocial interventions to standard opioid agonist treatments does not significantly improve abstinence from opioids or retention in opioid agonist treatment. So that's a bit of a surprise there. For agonist-antagonist treatments, I'm not going to go into detail on this except to say that the evidence all around is low quality, which means it may shift. So there's some evidence out there, but I think we need to wait until we have a bit more information before we draw any firm conclusions about that. We have good evidence on managing withdrawal from opioid use disorders, and we have the three good evidence for the three commonly used options, like alpha-2 adrenergic agonists like clonidine, and also buprenorphine and methadone. So we have good evidence that all of those works. And nicer touch than the psychosocial interventions with OAT, we have moderate quality evidence, so pretty good evidence that adding psychosocial interventions to pharmacological opioid withdrawal improves outcomes. It reduces dropout, increases compliance, and reduces opioid use during the withdrawal treatment. So add psychosocial interventions to your withdrawal, but there's no evidence that adding them to opioid agonist treatment is going to improve outcomes. So in conclusion, if you look at this overall as a bucket of evidence, what struck me is that we have really good evidence around opioid agonist therapies and opioid withdrawal management. We have good enough evidence that psychosocial interventions work for stimulant use disorder if you do them compared to nothing. But where we really are lacking in evidence is interventions for cannabis use disorder, which I think is interesting and important in the context of deregulation of cannabis and making sure that we have interventions available for people. We have inadequate evidence at the moment on pharmacotherapies for stimulant use disorder, and also we have weak evidence on alternatives for opioid agonist treatment. And I'm not suggesting that we necessarily need that, but it's just interesting when you start looking at the antagonist literature, the evidence is still quite weak there. Before I leave you, I just wanted to point out some strengths and limitations. This was a fun review in that you get a really broad brushstroke picture of where the evidence sits and what works, and sometimes what doesn't work, but quite often what you find is that there are gaps in the evidence. And it's important to keep in mind that what we've done here is summarize the available evidence from systematic reviews and from randomized controlled trials. So an RCT might have been done, but no one's done a systematic review of the evidence recently, so it will be missed. So it's only what has been summarized in those systematic reviews. So it's not a full, complete review. It's also quite difficult to combine the evidence statements. I've presented quite a few today, but there are a lot more. It's hard to synthesize them because of differences in the way the studies were conducted, differences in comparators, and it's important to keep that in mind, that it's a bit like combining apples and oranges sometimes. There's a lot of different bits of evidence to try and put together. Having said that, there's lots of really cool evidence in there, and we have an online website that Taylor's going to tell you about, and I would encourage you to go and visit it, because you might just find a really convenient evidence statement for your next endeavour. Thank you. I'll hand back to Taylor.
Thanks, Rebecca. As Rebecca mentioned, or as I also mentioned earlier in the webinar today, that this was part of a technical report that was written. And I don't know about you, but reading technical reports are not the most interesting thing in the world. And so, as Rebecca said, we did develop a website, and this was a way to disseminate the research findings from the technical report in a way that's, you know, easily accessible, it's timely, it's convenient to do, something that would be quite easy and accessible for policymakers, practitioners, the people who we think would really benefit from having this overview of reviews. So as you can see there is a QR code there, very fancy. Obviously, if you're on your computer and you've got your phone next to you, I encourage you to scan the QR code. Alternatively, you can navigate to the website, but I will just do that in the webinar today as well. Just to highlight that there may be a few clunks when using the QR code. NDAC has only recently just transitioned over to a new website, so we're kind of just tweaking out a few things to make sure it is feasible on a phone format too. So what I'll do is I'll just briefly share my screen and toggle through the website for you guys. So as mentioned, feel free to follow along. Cool. Yeah, great. So perfect. So as you can see here, this is what the website looks like. When you navigate to it, you scroll down, this is kind of a little bit of an overview of obviously what we did, so similar to what we've described to you today, and talks a little bit about how we, you know, extracted those evidence statements, what that looked like, and then as well discussed that key there, which I think is really important, obviously, when we're interpreting the evidence below. And you can see there when you scroll down, there's kind of drop down menus here. So as mentioned, the evidence statements that we looked at were related to cannabis use disorders, interventions for stimulant use disorders, and interventions for opioid use disorders. So Rebecca has provided a kind of a snapshot of what that looks like, and has kind of handpicked some examples from that. As she said, there's many more examples and evidence statements where that came from. So you can see, if you navigate to this website, just click the kind of plus, it spits out the rest of that there. So again, just easy to find. You've got the key quality rating down below, and then you can kind of interpret the findings there. Similarly, for stimulant use disorders, that's the same there with the key at the bottom. And the table for opioid use disorders is a little bigger, but kind of sectioned out into those headings that Rebecca went through today. So really super easy to navigate, really easy to access. A little bit more information here on that interpretation of the evidence. As Rebecca said, you know, there are some things to just be cautious about, and kind of, you know, for those who are super interested in reading the full technical report, you can navigate that here. So clicking on that link there will take you straight to that technical report. So yeah, feel free to kind of share, as Rebecca said, to kind of utilize those evidence statements for your own research or endeavours. But yeah, we hope you kind of enjoy navigating that, and we've absolutely flown through the webinar, but you know, short and quick is always nice. So thank you. Thanks for listening.
Thank you, Taylor and Rebecca, so much for that comprehensive overview of that work. That is definitely a mammoth project. Just while we transition to the next phase, I might ask for Taylor, Rebecca, and Marika to turn your cameras on, if you could, please. And just to comment as well, I think the visual evidence guide that you guys provided with that is such a simple and immediately comprehensible sort of scale of the evidence that, yeah, that is definitely a lot easier to manage. I'd like to thank Marika again for joining us. Welcome. And before we get into questions from the audience, I wonder, Marika, if you would like to offer any reflections on the overview that Taylor and Rebecca just provided.
It was a great work. It requires a lot of responsibility to synthesize all the available evidence on this, such a delicate environment like drugs-related issues. Also because, you know, there is a lot of discussion around, for example, what are the right outcomes when you consider an intervention. Rebecca mentioned, for example, the reduction in use or the abstinence, but there is a lot of discussion about it. There is an entire work on what are the most appropriate outcomes when you treat people with substance use disorder. So I think it was an excellent start for discussion, and you know that we are doing something similar in our organization, bearing in mind that it is very, very challenging. For the evidence is in continuous evolution, so it's very difficult to capture the moment, and because there is all the contextual factors around this very complex problem. So congratulations. It's a very challenging work.
Thanks for that, Marika. And while we move into the Q&A section, just a reminder, please feel free to drop any questions or comments that you have into the Q&A box, not the chat box, and we'll do our best to get through those in the rest of this hour. But as is my opportunity as host to ask the first question, Rebecca and Taylor, I was wondering, you know, you reviewed a lot of the literature and covered a lot of various use disorders and intervention types. Did you come across anything particularly unexpected or surprising, whether that be particular evidence one or another, or even gaps in the literature?
I think when we did this, we're actually doing it was commissioned by the MCDA, and they had certain topics they wanted us to cover. And the data that I presented today and the data that's on our website is about interventions for substance use disorders. And I've included that there because that was pretty straightforward. But when it came to looking at the evidence, say for interventions, early interventions for youth, or some of the work around marginalized populations or prisons, it was much more difficult to identify through the mesh headings. It's a much more of a nebulous literature. And yeah, it was, I don't know if it was so much of a gap in the literature, but it was very hard to identify the literature. Certainly, yeah, I think it's fair to say that what we did was very much driven by the questions that we started with, and it doesn't reflect the full scope of the evidence. I'm just trying to think if there was anything particularly surprising. There wasn't much evidence around some of the more interesting interventions that everyone wants evidence for. So it might be supervised injecting rooms, also on harms. So interventions where you've got an RCT to look at whether it's something reduces drug use, that was straightforward. But if you wanted to look at mortality or crime, that was really complicated because the RCTs are not the best method to assess those things because they're quite rare. And then with crime, there were so many definitional issues. It's like, is it incarceration? Is it arrest? Is it self-reported crime? And the outcomes were quite heterogeneous depending on the measure used. And I think that's what Marika is getting at, that, you know, it really does depend on the different types of measures used.
Great, thanks for that. On a related topic, we've got a question, an anonymous question, which comes back to maybe the questions that you had at this in initiating the review. Did you look at the comparative evidence for therapeutic communities or residential rehabilitation?
The comparative evidence, probably we didn't come across any, and I think that that is one of the limitations of this review, is people don't do RCTs of those types of interventions very often. So there isn't a systematic review that we could identify on that relating specifically to either cannabis or stimulants or opioid use. So keeping in mind, like, we didn't go out with a view to finding that evidence, so it might be there and it just wasn't falling into our boxes. But yes, that was one of the problems. The other problem with doing this type of approach is the evidence evolves over time. You really see that when you're trying to capture everything at once. So you could find papers and research trials that showed that methadone was better than not doing anything at all, or better than doing a non-methadone type treatment, like maybe a therapeutic community. I'm not sure what the comparator was. However, then you move forward in the literature, and the next set of literature actually looks at buprenorphine compared to methadone. So you don't get the comparison between buprenorphine and no intervention. So it makes it quite hard to compile. There are gaps, and with good reason, but it makes it a little bit hard to compile. But I'd love someone to go and search for that literature, but I suspect the challenge is that there aren't many RCTs to pull together.
No, that makes a lot of sense, and the change over time of the evidence as well is an interesting component to try to factor in, and just complicates what is already a very mammoth project.
Maybe they were before 2010. That's the other possibility. Yeah.
Thank you for that. There's a few other questions. I'm conscious of not wanting to drill into any particular finding too much, especially relying off the top of your head, but one of the feedbacks was around the website, which or the online visuals, which is amazing. Sarah Farnbach said from NDAC, lovely talk both. Great to see research made in a very digestible format. Just wondering if you could talk a little bit about the process of building the website, the technical side. So any tips, tricks, or learnings that you gained along the way.
It depends if you mean the key or the website. I can say with the evidence key that we developed, that was like a traffic light system. I was quite proud of that, and we showed it to the MCDDA and they loved it. And then one lesson from that was that it didn't pass the colour blindness test. So I think that they weren't able to use it in the end. So that's something that might appear accessible to us, but it's not accessible to everyone. And I think Taylor might want to comment on the challenges with the website.
Yeah, I guess as mentioned, like, the website was one idea that we had talked about as, you know, an easy, accessible way to disseminate the information. And I guess the initial process was, to be honest, fairly easy. Like, Rebecca and I just kind of sat down, even just in a Word document, you know, thinking through how to best present this information in a way that is really easy and digestible. So, you know, like, thought through kind of what those like tables would look like, and how we'd want people to like navigate the website, even little things around, you know, clicking the headings and then dropping down, rather than someone kind of getting straight to the website and seeing everything in their face straight away can be a bit overwhelming. More recently, some kind of ironing out some issues even now around the website. Poor Laura from Comms is dealing with us at the moment, but that's more so around like transitioning the website to its new format, as mentioned before. But I guess all in all, like, it is a fairly easy way to disseminate, and I would encourage people towards the process. It wasn't too difficult, but yeah, we'll just say, like, you want a really good idea around you know, what that's going to look like, and it can kind of take some time to work that out. But also, I think it's around viewing it from the eyes of the policymaker, or viewing it from the eyes or the perspective of the clinician or the practitioner. rather than, I guess, from like the researcher. So really thinking through, you know, the technical report is there for people who really enjoy all of that information, but thinking about, you know, if I'm someone who just wants to kind of have kind of that information quick and accessible, what do they want to see? Do you want to add to that?
I was just thinking Marika might be a good person to ask about that, because they have the evidence portal, which is a way of disseminating information to policymakers in the EU.
So are you asking the process for building the best practice portal?
Well, I suspect our audience are probably not familiar with what you've done at all. So even just explaining that you have a portal and how you use that.
It is a long story. I try to make it short. So when I joined the center, there was a practice database of mainly focusing on prevention. As I mentioned before, as I came from the Cochrane group, the first idea was to try and systematize and reproduce their synthesis of all the available evidence. And then we try and we pass through different phases. There was a beginning, we really use the same concept of the Cochrane collaboration. So population intervention comparisons and outcomes, but it looked like dry for the ones that wanted to apply the evidence rather than studying. Because rather than addressing clinicians, we wanted, as you, to address the policymakers and also practitioners at different levels. So there was a period where we made an effort to produce synthesis in a very plain language, to make sure people beyond the analysis and the report of the statistical meaningful of the interventions, they could really understand what was the practical translation. And then we tried to get back and to have something more structured. So what I would say is that is a continuous process of trials and errors where you test with your public what is better, and then you are always ready to rediscuss and to change what you are producing, bearing always in mind that decision-making is a much more complex process than simply translating the evidence. So also bearing in a way the frustration of seeing what you produce interpreted differently or considered differently, or focusing on what is missing rather than what is there. But this is part of the game. The moment you decide to do a website, you are leaving behind your academic environment addressing publications, and you are entering in the arena of the interpretations. Imagine we work for people speaking 23 different official languages, and I underline official because then there are many others. So only translating one of your statement, the statement you waited for months deciding what's better, then is translated in another language and probably assumes a completely different meaning. Okay.
And that's something we certainly found. There was one statement that I didn't include about cannabinoids, and we had some very firm discussions, because after having reviewed the different reviews on it and thinking very carefully about what the results meant and synthesizing them, then I would get a very strong pushback. No, you can't say that, that's wrong. And then we had to go, well, actually, there is enough evidence, and really make a strong case that the evidence was enough to make a statement, which would be unpalatable to a lot of people. But that's the interesting part. I'm not going to be drawn into saying what it was, but just please go and read the review and you'll find out.
I can imagine. I also think the evolution of the language, as we became aware of risks of stigmatization. So myself, I published reviews where in the title, following the indications of the Cochrane collaboration, you had, for example, heroin users But then the development of the awareness around the language now would be people who use heroin, for example. Or for long years, we talk about sex, but now we know that sex and gender are different things. So the work is complex because the evidence is in continuous evolution, because the language is changing, because the way people look at problems is changing. So it's really be prepared for a continuous evolution where quite often you realize that you finish working on something and the new challenge is already there to wait for you.
Great points. We keep coming back to this point of the, evidence is forever ongoing and ever evolving, I guess, and it might be too early for this question, but is there plans to expand or redo this review in X years' time?
I think it would be a good idea to do it. And I mean, I've kind of held off because it still takes resources and time. Like we pushed everything aside to get this done in 3 months and a pretty tight budget. But my view is it's such a broad brushstroke thing that the evidence, even though there's lots of emerging bits of evidence, it's going to take a while before they filter through into systematic reviews, and most of the broad brushstroke statements haven't changed. Even the stimulant stuff, which I follow fairly carefully, the latest systematic review basically shows the same thing as we concluded on the previous evidence. So I was like, oh, we have to update this, and actually it's not going to change the evidence at this point in time. So we need, in my view, I mean, for that particular area, we have more reviews than we have trials. It's quite funny. So I think we need to wait until the evidence builds up. But for some of the newer areas, yeah, maybe that will change. Or maybe we just need to do the reviews, the broader reviews, to base this on. Maybe, I would say every 5 years, probably.
Yeah, I can understand what you mean, that even an additional literature may not necessarily change the final, star rating for quite some time. I am intrigued and appreciate the strategy to focus on RCTs, but as you said, for some of the outcomes that are really hard to sort of evaluate in an RCT, that some of the observational studies might be able to fill in some of that evidence gap as well.
We did notice a change in terminology. I just noticed Ariane's comment there, and we took the terminology used in the papers, but it does change over time. And yeah, there are some things in there that people are like, oh, that's a bit old school or different or inaccurate, but that's just a reflection of the history of the field.
Most definitely. Thank you for clarifying that. Another question we have, and it comes back to sort of the priority populations or the specific subgroups and the intervention effectiveness among those. There was a question of whether you were able to identify evidence for those with coexisting history of mental health issues and particularly psychotic illness.
We didn't in this review. We did come across a few reviews that did do that. And if you have a look at the tech report, you will find them in the appendix, and you might find reference to them in the main part of the paper. But it wasn't the primary purpose of this particular exercise. And because we were really short on time and resources, we did focus very much on substance use disorders, and we didn't have we just didn't have the resources to delve into that level. But the evidence also starts to peter out because you're looking at RCTs, reviews of RCTs, and then we're trying to review the reviews. So by the time you get to that stage, you've got one here and one there. But they will be listed in the appendix of the tech report. So if you're interested, go and have a look.
Fantastic. I do wonder if while we're talking in the last few minutes, if we might be able to share the link maybe in the chat just for easy in case anybody's dropped in late and wasn't able to grab that QR code. That's fantastic. Another question, and there's some acronyms in here that I can't tease out, so hopefully you'll have a better sense than me. Anonymous has said the website is very useful. It seems surprising that PSIs do not enhance treatment outcomes for OAT. Does this mean that putting resources into PSIs and case management for clients on OAT may be an outdated model? Practically, would we be better offering prescribing and contingency management only?
That's a very good question, and I think this speaks to the interface between research and policy, that these things don't occur in isolation. And while adding psychosocial treatments to OAT might not reduce heroin use more, and they might not improve retention in opioid agonist treatment, does that mean that we shouldn't offer people psychosocial support full stop? Because it might be quite beneficial in a range of other ways. And I think we have to be really careful when we say, let's not do this because of the evidence. We just have to be aware that you shouldn't add counselling to OAT and expect people are going to reduce their heroin use more. That's what this is telling us. It's not telling us don't provide counselling. Does that make sense?
Definitely, and I think it comes back to the point I think you and Marika made about the outcomes being assessed and do they make sense, and are they addressing the question of interest?
And we definitely need that dialogue, and I think the EU guidelines do that much better than what we've done here, in that they provide that context, and that context and clinical interpretation of the evidence is critical.
Thank you. Another question from the audience: is there a similar review for alcohol use disorders?
No, but if you want to do one, that would be great.
There you go, Anonymous. That's a call out for it. Another question, you know, the scale and the rating system that you guys compiled. Can you speak a little bit about some of the design or methodological features that determined the quality of the evidence? Obviously not going into too much detail, but yeah, just a little bit of a teaser of sort of how you rated the evidence.
Yeah, absolutely. So we use the Cochrane grade rating system, and where that was already done in a Cochrane review, that was very easy. Where it wasn't done, I had to actually go to the reviews and have a look and do my own Cochrane grading. So for those who aren't familiar with it, and I'm just trying to remember off the top of my head now the types of things you look at, and Kriana, you know this better than I do, but you want to have consistency of the evidence and not too much heterogeneity, enough studies that you can sure of the robustness of the findings. It's that type of thing. So for stimulant interventions, for example, we've got a very small effect. So it's kind of borderline. We're not sure whether it's significant or not. And depending on which review you look at, you might get variation in the results. So you're getting inconsistency in the results, and that will bring down the quality of the evidence. And what it means is that one study has found an effect and the next one hasn't, or the next one's found the opposite effect, and that reduces your confidence that you're going to be able to replicate that result. And whereas if you've got lots of really large scales and they're all showing the same or very similar effects and they're all within certain limits, then you would feel much more confident that if you did the intervention again, you get the same effect. I mean, is that a fair way of expressing it, Kriana? Sorry to put it back on you, but you
no.
I asked the question. I do.
No, I think that's really good. We can obviously go into the details of it all, but I think that's a great summary. Thanks, Beth. We are in the last little bit of this seminar. I wonder, are there any sort of last thoughts or comments that anyone here on the panel wanted to mention or add to the discussion so far?
Can I say something about there is an important distinction, especially for the ones using the evidence, in this case, decision makers, about lack of evidence or evidence of ineffectiveness. There is a huge difference between having studies proving that something is not effective or even harmful with not having studies. Because the reasons why there can be a lack of studies are many. Lack of investments, lack of difficulties in recruiting some for example, particularly vulnerable populations, people without a house, people living in prisons. So when we say lack of evidence, we need to distinguish carefully the reasons why this evidence is not there, and helping people to differentiate between, as I said before, the lack of evidence with the evidence of ineffectiveness. Because in the first case, interventions can still be adopted, bearing in mind that we need to be responsible for covering up for that part of certainty that is not there. While if something has proved to be harmful, this shouldn't really be provided to people, shouldn't be implemented at all. Thank you.
No, that's a really good point. And that's where that visual scale of the evidence quality really gets added. It's not only whether it's a positive or negative effect, but the scale of that effect, and at the bottom with question marks all along the rows. Yeah, it's a really great point. Thank you, Marika. We do have another question from Marianne. Thank you. Did you cover the question about methadone being equivalent to appropriate dose of buprenorphine?
Did I cover that? I think that was one of the evidence statements. Is that the question?
Yes, I imagine that that's what it is. Or yeah, did you cover the evidence of it? I think that was summarized in your results.
If I can remember correctly, it was moderate quality evidence that buprenorphine at 16 milligrams was equivalent to methadone. And there are some more nuanced evidence statements that you can take a look at on the website. The evidence is maybe a little bit lower. It's in that kind of range where it may or may not be the case. So I didn't present them today, but it looks, you know, in excruciating detail about impacts on retention and things. And I didn't go into that today, but you might want to have a look at that.
Fantastic. Thank you. Unless there's anything more to add at this point. Oh, sorry, we got a clarification. We will take the opportunity while we're doing. Whether or not there was, in fact, evidence that methadone maintenance treatment was a bit better. But yeah, she'll take a look at the tech report as well. So
I think that's also important that we haven't included effect sizes in here. So it's just a very blunt, it's the same or it works, and that's all we've got. It's a very important consideration. In some contexts, we might, you know, what is better? How much better does something have to be? And then you're starting to look at cost effectiveness and implementation and other issues that play into this, not just does it reduce drug use or whatever. You can see this borne out really clearly in the studies of school interventions for prevention. There's very, very good evidence that they can prevent the uptake of drug use in some cases, depending on the type of intervention. But when you look at the effect sizes, it's so small that you have to bear in mind that, yes, it works, but it's having a little tiny effect. So that's always an important consideration as well. These evidence statements shouldn't be taken on their own. You have to go back and actually look at the original reviews to understand how much of an impact something is having and at what cost.
Yeah, really great point. It's an umbrella review and it is comprehensive in its value, but yet not the whole story in that piece. Look, it is a mammoth piece of work, super comprehensive and accessible way of accessing it. We might wrap it up there, but I would like to thank Taylor, Rebecca, Marika again for making the time today and providing such interesting and informative discussion and sharing your insights. It's been a fabulous time. I'd also...
Sorry, jumped the gun.
Not at all. I'd also like to thank everyone in the audience for joining and engaging in this discussion. I might ask you guys to turn your videos and cameras off, goodbyes as well, and we'll cover off the future weeks. Thank you for all.
Thank you.
So coming up in future NDAC events, next week on the 21st of March, we'll have NDAC's own Dr. Calvert Tisdale talking about using data linkage to determine the long-term health and substance use outcomes of residential substance use treatment. The week after that is the Easter weekend, so we will be taking a break and we'll be back to regular programming as of April 4th. And just a reminder as well to save the date, Friday 20th of September, for NDARC's annual research symposium. But for now, have a fantastic Thursday evening all. Thank you to the presenters, our panelists, and our audience. We will see you next week.